it's become a thing. And I'm referring to severe restrictions on normal social economic activity. It's not appropriate, I think, to use the term lockdown to describe all non-pharmaceutical interventions. So wearing a mask is not lockdown. Forcing people to wash their hands is not lockdown. Tracing people in their daily activities is not lockdown. By lockdown, what I mean is severe restriction on social and economic activity. People usually have to stay at home for almost all of the time, except where they absolutely have to go out for a specified set of reasons. It's a reversal of the normal situation in a broadly free society where you can do what you want unless you're told not to. When there's a lockdown, you can't go outside of your home unless there's a specific reason that you're allowed to. And they were a universal recommendation from the World Health Organization at one point. They've become, they're not anymore, obviously. They've become the most prominent anti-COVID-19 strategy, and there's been a huge amount of debate in the West. And I don't know what the discussion has been like in Korea, but in the West, there's been a huge amount of discussion about whether it's the right thing, and it's become highly politicized. What's interesting about them from a philosophical point of view and from a public health point of view is that they're relatively untested. It's fairly rare to lock a city or a country down. And so there's not a whole lot of evidence about what happens when you do. Either evidence about the spread of infection or evidence about the other health impacts of what you're doing. And also, obviously, lockdowns have drawbacks. I don't think anybody thinks anything else. I don't think anybody disagrees with that. There are many obvious reasons why you shouldn't do a lockdown. So that makes them interesting too, because they're a high cost measure in many ways. So for all these reasons, it's interesting, and it's remarkable, really, that they've become that they were a preferred measure, and I think is going to be a topic for considerable reflection for some years to come. I'm going to make 5 claims of increasing strength, if you like. They sound increasingly controversial. And I don't, I want to just again emphasize, I don't want to offend anybody or upset anybody. I'm not trying to minimize the seriousness of COVID-19 or anything like that. I'm not taking this view that, oh, it's not a serious thing, it's not real. I'm not a conspiracy theorist. I'm not a supporter of Donald Trump. None of these things applies. So I just want to make those things clear up front. Nonetheless, just on an intellectual level, I think that several common arguments for lockdowns fail. That's my first claim. My second claim, which is a bit stronger, is that lots of actual lockdowns have not been justified, and moreover, they've actually been wrong. There are other measures that would have been better, both in that they would have been more effective, probably, and that they would have been more morally justified. Thirdly, I think, and this is where it gets more controversial again, lockdowns shift the burden of disease from the powerful and the wealthy to the less powerful and the poor when you take a global perspective. So lockdown takes health from the poor and gives it to the rich. And that's why I think they are not egalitarian. They are contrary to equality when imposed as or when promoted as a global response, as a default response. Fourthly, and this gets more controversial again, I think the fact that lockdown became so popular is actually because lockdown is unfair. It is because lockdowns favor the interests of the rich and powerful that they were promoted, because rich and powerful people are able to promote their interests. So I'm not saying that the unfairness was why people wanted to lock down, but the fact that the lockdown was unfair is part of the explanation, and in a necessary part of the explanation for the fact that lockdowns became so popular globally. And then fifthly, and this is a kind of an optional extra, because I don't have any interest in partisan politics. But fifthly, the favoring of lockdowns by the left, at least in the Western context, and their rejection by the right, the political right, has nothing to do with their intrinsic character. It's more about which side happened to pick which side. And that obviously flows from my argument about lockdowns violating equality. They do violate liberty, but they also violate equality. And so if it could easily, in a different world, things could have been different. It could have been that the right defended lockdown and the left opposed lockdown. I'm not going to argue that lockdowns are always wrong. I'm not going to argue that COVID-19 is not dangerous. I'm not going to argue that people should do nothing about it. I'm not going to argue that COVID-19 is a fiction or a conspiracy. I'm not going to argue any of those things. I'm not also going to comment on any political party or figure or cause or anything like that, because I just don't think it's helpful to do so. That's what newspaper columns are for, and most of those are not helpful for most things. So I just want to make clear again what I'm not doing. There are also a lot of things that I think should be discussed in could be discussed, but that I won't be discussing here. So apart from a few examples, I'm not going to do a kind of empirical analysis of COVID-19 in the whole world. I think my argument actually requires one to make it fully fledged, but I'm not going to do that here. I'm just going to give some examples. I'm not going to talk about the role of modeling in prediction. There's been a lot of discussion of modeling and modelers, and should we trust the modelers, and do modelers get it right? What do models tell us? What's the difference between a projection and a prediction? I'm not going to I'm not going to discuss those things. I'm also not going to discuss causal inference at any length. And more abstract matters about the way science relates to policy, the way that culture, political system, and responses all connect, about financial interests, and all these other things. They're very interesting, but they're not what I'm going to be talking about here. So COVID-19 began, as you all know, on the last day of 2019 in China. At least that was the first reported case. And what happened next prompted really a global response, because hospitals were very quickly overwhelmed. And the Chinese authorities locked down Wuhan in a very serious way. It was not possible to go in or out. People were not allowed out of their homes. But despite that, it reached the rest of the world because it had got out before that lockdown happened. And in March, scientists at Imperial College London on the 16th of March produced a very influential report, which wasn't published in a formal way. It was a report predicting dire consequences for the UK and for North America if action wasn't taken very fast. And on the 26th of March, if I'm not mistaken, they produced another report in which they extended these results to the whole world and projected very serious consequences for the whole world if action wasn't taken very fast. I'm going to talk a bit more about those reports because they were, I think, instrumental in shaping how people think about COVID-19 and about lockdown. What happened then was that much of Europe, Africa, and many other parts of the world locked down, although many parts didn't. My understanding is that in Korea, there was never a lockdown. There was contact tracing. Sweden did not ever implement a full lockdown. America adopted no national level response. Brazil also didn't, and various other countries as well. So it wasn't universal, but certainly in much of the media in the West, there was a lot of, if a country had not implemented a lockdown, it was subject to a very serious media scrutiny. So this created this sort of feeling that the default, the standard measure was to lock down. And if you weren't doing that, you were doing something wrong. It's also the case right now, I'm in the UK, it's also the case that it's become the default response. So if in Britain, if cases can start to rise again, which they are currently doing, the question becomes, should we lock down again? So it has become, in some places, it has become seen as the response, the way to respond to COVID-19. In other places, not. And I'll say a little bit more about that later. Some places tried it and then never did it again. I'm not going to spend time on the characteristics of COVID-19 because I'm sure you all know it better than I do. It transmits in the air, we now know, more than on surfaces. And it is particularly interesting because it attacks old people much more seriously than children. And this, I think, is a crucial, I mean, it's central to the argument that I'm making. If it didn't have that characteristic, this whole thing would have a quite different shape. Excuse me, I'm just going to open a window. It's summer here, and this is quite unusual in the UK. I'm not used to my study being too warm. So several common lockdown arguments fail. Let me start by explaining a bit more about the report that I referred to earlier that was published on the 16th of March by Imperial College London. It just concerned the UK and the US, but it set the tone for what came later. What that report did was it took a range of policy options, a whole universe of possible policy options, and it said there are essentially only two things you can do, and they are defined by your goal. If your goal is to reduce the reproduction number below 1, that is a suppression strategy. If it is to allow it to be at or above 1, but keep it lower than it would otherwise be, that is a mitigation strategy. And they said these are the two fundamental strategies. And they said you can achieve mitigation, you can achieve suppression if you reduce social contact by 75%. So they effectively took a very large range of possible strategies and they reduced it to a binary choice between reduction of social contact by 75% and everything else. And they then said there are going to be very severe consequences if we don't do this, this strategy of suppressing and reducing social contact by 75%. And they were very clear in that initial report that this was really the only viable strategy for the UK and for North America to follow. 10 days later, they published this global report, which is the one I've indicated in this table. And they're not as clear there that they don't say this is the only strategy you can take, but they do say that if you don't undertake suppression very soon, you will see terrible outcomes. So they say, look, an unmitigated epidemic will lead to 40 million deaths, 7 billion infections. That's almost everybody in the world. If you mitigate it, you'll get 34 million deaths. If you mitigate, and then you put extra protection in the elderly, which is modeled as a 60% social reduction, sorry, 60% reduction of social contact for the elderly, then you will get 20 million deaths. If you suppress, which is 75% reduction of social contact, you'll get 10 million deaths if you start at 1.6 deaths per 100,000 a week, or 1.9 million, so basically an order of magnitude lower, if you start at 0.2 deaths. So what this basically means is that you're going to get much, much better results if you immediately put in place measures to reduce social contact by 75%. So the net effect of this is to make it very, very difficult to do anything, even to think about it, because of the time involved. If you start now with your lockdown, you're going to have 10 times fewer deaths than if you start in 2 weeks' time. So that's the situation that is being reported here. And the result is that it's very difficult for people to think about things. This is particularly important, of course, for countries where there either isn't sufficient epidemiological expertise to assess these predictions, or if there is such expertise, it's not accessible to politicians, or politicians and science, politics and science aren't properly connected. There aren't advisory groups in place. The politicians don't know who to ask. And so if you're a leader in Africa and it's really quite difficult to know what else to do than to look at this table and see what your prediction is going to be in many regions in Africa. I mean, I don't want to undermine the epidemiological expertise there. There is considerable epidemiological expertise, but the situation of government in many less developed parts of the world is such that getting scientific advice for policy isn't something you can do at immediate short notice. It's complicated. What there wasn't in this report was any modeling of the indirect health impact. And there was, of course, no modeling of the economic impact. There was a mention that in some places these might be quite severe, but there wasn't any actual modeling of these. To my knowledge, there isn't at national level anything like such significant modeling of the health impact of measures like that are being taken to control COVID-19 in any places that I'm aware of. We're just not seeing the same level of modeling being done, or if it is, then it's not getting the publicity and it's not being done by the same people. So what exactly is the argument here? This was taken as a good reason to implement a global recommendation, or to make a global recommendation of locking down, and in many places lockdowns were implemented. So in many countries in Africa, for example, lockdowns were implemented. But what exactly is the argument? I think it's not clear. There are a number of things one can take from this. There could be a kind of a precautionary idea. Look, we don't know what we're dealing with. Better safe than sorry. Let's just stop COVID with a kind of gung-ho attitude. There could be an idea we're just going to wait, or we've got to protect the health system. That comes up a lot as well. None of these things really amounts to an argument, because none of them takes much into account. They just don't. They're just not arguments. They're just ideas, and it's not immediately clear what the argument for from those conclusions to a given measure is. And I think that it's actually it remains quite unclear, because there hasn't been any attempt to. Well, sorry, I don't want to generalize. There have been such attempts, but in public discourse, there is generally a lack of connecting COVID-19 with existing ethical frameworks that we have for making decisions of this kind. We have bioethics, which has been going for years and years and years, and has developed ways of thinking about problems to do with human health, and has identified different ways you could approach those problems and different opinions you could have, and has also ruled out certain things as attractive arguments that we actually shouldn't use. You can't get the answer to a complex policy question from a book, but if you consult the existing ethical frameworks for making these sorts of arguments, then you can get, I think, a clearer understanding of the decision we face. I think this is not an unprecedented situation. You know, everybody says it's unprecedented, but it's not unprecedented. We've routinely faced decisions about how to allocate resources in ways that will affect lives. And we also have specifically faced epidemics before. So it's not the same as previous cases, but nothing is the same as things that have happened before. Everything is new in some, unprecedented in some sense. And I think thinking about it as unprecedented and saying it's unprecedented was an attempt to get people to take it seriously. Unfortunately, it's backfired because it's robbed us of our ability to refer to what we do know in making decisions. So one familiar framework for taking ethical decisions is precaution. And this is usually understood in terms of a precautionary principle. And the precautionary principle can be theorized in more than one way, but it's usually thought of as having three parts. One is a damage condition, saying something really bad might happen. The precautionary principle is particularly familiar in the context of environmental science, where it's used to justify taking actions in a situation of scientific uncertainty. So there has to be some damage that is going to happen, or might happen. It's possible that it might happen, and it's really bad. And then the knowledge condition, there's uncertainty. We're not sure whether it's going to happen or not. And then there has to be a remedy, which there has to be something we can do to avoid it. And in this situation, the precautionary principle says you should take that action, you should implement that remedy, even though it's not clear whether the damage is going to occur. So it basically says when the risk is high, is serious enough, when the damage being risked is bad enough, we should take action against it, even if we're not sure about whether that damage is going to occur. That's what the precautionary principle says. And you can see something like the precautionary principle was even being used by the Scientific Advisory Group in the UK in October of last year. So that's not at the outset, that's just, you know, half a year into the pandemic. They said in a report they released, the evidence base into the effectiveness, they shouldn't, that's a typo on their part, but this is what they said. The evidence base into or of the effectiveness and harms of these interventions is generally weak. However, the urgency of the situation is such that we cannot wait for better quality evidence before making decisions. So what they're saying is, look, we don't know whether these measures that we're recommending, which were lockdown basically, are effective, but we don't have time to wait for evidence. The trouble with the precautionary principle in this context is that I don't think it is satisfied globally. There are maybe places in the world where it is satisfied, but in many, and I would even venture to say most places in the world, it is not. And this was not seen because the precautionary principle was formulated and applied by people by wealthy people in wealthy places. So I think at the time to apply the precautionary principle has passed. It would have been applicable in March, but it's not really applicable now. We have had time to assess the evidence for effectiveness of different measures and so forth. But the remedy, even in March, I think it was clear that the precautionary principle is not met, and that's not because the damage wasn't serious. The damage is serious. The risk is serious. Um, it's because the remedy condition isn't satisfied, because you just can't reduce social contact by 75% in many places in the world. There are many places where people live in crowded conditions, and you can't reduce social contact by 75%. It's also the case that if you tell people to stay at home, you may actually increase social contact in some such cases, and that's been observed in some places. For example, there's some suggestion that happened in Accra. It's also the case that implementing these measures will have their own health impacts, and you obviously have to consider those if the remedy is supposed to be a remedy for a threat to health. It's not a remedy if it causes too much damage. If we don't include that condition, then shooting yourself in the head is a good remedy for cholera, because instead of, when you're at risk of cholera, you just shoot yourself in the head and then you won't get cholera. So we have to consider the damage that is caused by the remedy in respect at least of health, even when we're applying the precautionary principle. This is not the same as saying you have to do a cost-benefit analysis. I'm just saying that where a remedy has costs in the same dimension as the damage you're considering, those do count when you're considering whether it even is a remedy. And in very poor environments in particular, these health costs can be very severe. It may be that they take longer to show up, and this is quite interesting as well. The effects of malnutrition and of disruption to education on long-term health and on the disruption of HIV and TB programs and so forth are things that are going to, echo down the generations. So it's not something that's going to necessarily be, people are going to be dead within 6 weeks. But that doesn't mean that you can just ignore them. And I think these are very significant. I think everybody acknowledges there are some such health impacts. What I think people haven't realized is that in many parts of the world, these are very, very serious. They're not just like sort of a side issue. And yeah, as I said, lockdown in overcrowded conditions can increase transmission even. So it can even just not work at all. So the remedy, there is not, I think, an application of the precautionary principle globally, because it's not the case that that lockdown is a remedy globally. Another way to justify a measure is with a cost-benefit analysis. The trouble with this is that it takes with a utility calculation of some kind. It doesn't have to be a formal cost-benefit analysis, but some attempt to weigh up the pros and cons. Commonly people just don't do this, and then they say, well, it's just too difficult. So I think it's generally accepted that there hasn't been, or there at least early on wasn't a good cost benefit, a good utility-based justification for locking down. People usually, when this is raised, they just say, well, it's not reasonable to do that. It's not practical. We should do a precautionary. This was a precaution. But I've just explained that in many places, precautionary reasoning was not appropriate. I think for a utility calculation, it's pretty clear that there hasn't been in many places there just hasn't been a proper utility calculation. I'm wondering, for example, about South Africa at the moment. I don't know. I still don't know whether there have been significant projections or serious projections of the impacts of lockdown on health in the longer term. And I'm sure that in many other African countries, there haven't been. So what are the projections? What are the health projections for the region going forward for the next, say, decade, based on what has happened in the past year? There is work like this being done, but it's not being given the same prominence, and it's not being centralized and supported by governments in the same way that work on COVID-19 is. And that's you know, that just means that they're just, you can't, you know, there just isn't a cost, there isn't a utility calculation being done. I just haven't seen a decent case made for lockdown on the basis of utility calculation. I think that's remarkable. You know, it's now over a year into this, and it's not, you know, it's remarkable that this approach, which is the standard approach to taking policy decisions, isn't more widely focused on. A third approach is deontology. Which is to say, a deontological approach is one that just says, look, there are certain things we just should do. You know, murder is wrong, you just shouldn't do it. Lying is wrong, you just shouldn't do it. End of story. And there are some arguments for lockdown that invoke categorical imperatives, but I don't think they are very serious, really. For example, when you say, for example, we must save lives, we can't trade off lives against anything. That's invoking a deontological approach. But of course, it's not enough to motivate a lockdown, because there are so many other categorical imperatives that are violated by lockdown, such as the right to feed yourself and your family, liberty-based ones, which I mentioned already, but many others as well. And lockdown itself costs lives, obviously, according to anybody. I don't think anybody's going to pretend that there's no health burden of lockdown. And so you're already engaged in some kind of a trade-off. And this is why deontological approaches are not very helpful for policymakers. Maybe they're useful in individual cases, but for public policy, deontology is quite difficult to apply for this reason. So I don't think we need to spend time on that. So far what I've just said is that there haven't really been good arguments mounted for locking down as a global measure. I'm not saying that there's been no good argument for doing it in any particular region. Some regions maybe have had good arguments. I'm not saying anything about that. Maybe they haven't. I'm just saying that there hasn't been a good argument given for the fact that this for the fact this was ever a global recommendation, and for the status that it has come to enjoy globally as a kind of a default or a go-to measure. And now I'm going to argue that in actual fact, not just were many of these arguments, were many lockdowns unjustified, but that they were actually wrong. I've argued that they were unjustified because they weren't covered in many cases by a precautionary principle. There was no utility calculation, no balancing of costs and benefits, and there isn't a clear basis in any categorical imperative to lockdown. But I'm going to go further and argue they actually were wrong, because the costs were too high, the benefits were too low, and the effectiveness was too poor. And that this was known, or should have been known, and was obvious to some people at the outset. So this is not hindsight only. I'm going to talk about South Africa, which is an interesting example. It is actually, I've said here, it's a lower middle income country. Actually, it's technically a higher middle income country. It doesn't feel like that because it's extremely unequal. So there are some very wealthy people in South Africa. You can live very comfortably, but there are a lot of very poor people. It's one of the most, if not the most, unequal countries in the world. The median age is 26 and the life expectancy is 60 for men and 66 for women. So it's about halfway between European and, well, less than halfway between European and African countries. In Africa, the median age as a whole is 19, and in Europe it's 40. So you can see from that it's a country that's sort of in a sort of transition zone. It's about 55% live below the upper bound poverty line. So there's a lot of very poor people. 47% of households have access to piped water. So still less than half of households have water piped into their houses. The leading causes of death are TB and diabetes. So again, you can see it's in transition here. It's it's got an infectious disease as a major cause of death, and it's got a non-infectious disease as a major cause of death. TB is the leading cause of death for men, diabetes for women, and that has obviously to do with HIV, because many of the people dying of TB have HIV. What are the costs and benefits of lockdown in this situation, where a benefit is protection against a risk of COVID-19? So I'm drawing here on work that I've done with some colleagues that I mentioned at the outset on the slide at the beginning. This is a graph showing the caseload over time, and this is on the line is on a logarithmic scale, and the bars are untransformed case counts. So South Africa had its first case on the 5th of March, and then it entered and it implemented mitigation measures on the 15th of March, and then it entered into a full lockdown on the 26th of March. This subsequently became known as level 5, and it's indicated on the graph as 5, as the arrow 5 here. It then dropped down to a level 4. It decided it was going to have 5 levels of lockdown, 5 being the most serious and 1 being the least serious. It dropped down to level 4, which was still very strict. In level 5, you were not allowed out of your house even to exercise. It was very, very strict. You could only go out to go shopping. Level 4, you could go out to exercise for an hour between 6 and 9 a.m. in the morning, and that was it. It was still very strict. Level 3 is not really a lockdown anymore. People are allowed to get together and they are allowed to go to work, but there are restrictions. Level 3 amounts to mitigation measures, and so do 2 and 1. They're more relaxed. So what's interesting about this graph is what it doesn't show. So you don't see any sharp changes in the climb of cases between about the end of March and somewhere in, I don't know if you can see the cursor here, but somewhere around July. You'd obviously have to do a proper analysis to be more precise about this. But the point is that you're not seeing anything major happening, and that's despite the fact that there was a massive change in regulations occurring here. So they implemented a major lockdown. You do see a big change of angle here, but that occurs on almost the same day that lockdown was implemented. So it's impossible that it was because of the lockdown. It could have been due to a number of other factors. I'm not sure what, but it's impossible that this was due to lockdown, because obviously it takes a few days, maybe a couple of weeks, for lockdown to have an effect, because that's how long it takes for the virus symptoms to show. So anybody who already had the disease would still be developing it and showing symptoms for the first couple of weeks of the lockdown. Then the lockdowns were gradually lifted, and there were still very few cases. And what's interesting is that during level 3, the first peak occurred and then went down again. So there's just there's nothing to explain this decrease in the implementation of a lockdown. There just wasn't anything that was done in terms of an implementation of a regulation that can explain the fact that this peaks and went down again. In fact, regulations were being lifted, and then they carried on being lifted, and then there was a second wave, which was due to a new variant, and it went much higher. What's interesting here is that the government never went back to level 5 or level 4. It went to a mitigation level, which is level 3, even though the wave went much higher. I suspect that's because they realized that there was just no added benefit to going to levels 5 and 4. So it's quite plausible, I think, that mitigation measures had an effect in South Africa. You can argue that plausibly. It's quite hard, I think, just looking at this graph to see how one would even begin to argue that the more severe measures that took place in May and June, sorry, in May, April and May, sorry, of 2020, that the hard lockdown measures, it's very hard to argue that, to see what effect they had, to argue that they had an effect. And I think it's very interesting that the government, even when it was faced with much higher cases, didn't implement those second time round. And I think it was sensible of them not to do so. I think what's interesting, so I think it's very hard to argue that lockdown was effective on a national level. And that's because, of course, on a national level, when you implement the regulations, you don't actually get a reality on the ground that maps this. People aren't actually staying home when they're living in township situations. They are staying home in suburbs. And here we've compared the suburbs, some suburbs and some townships in Cape Town. And this is very interesting too, because what you see is that in the top graph is suburbs and the bottom half is a township. And what you see is that in the first wave, it's much higher in the township, and the second wave is present in the township, but more muted. The second wave is much lower. Sorry, the first wave is much lower in the suburbs, and the second wave is much, much higher. And what this suggests is that the lockdowns were effective in suburbs, but not in townships. Townships are overcrowded slums where a lot of people are living. Suburbs, much more wealthy people are living. They're able to distance effectively, and a lockdown means something. And this, what this suggests is that in an unequal setting, a homogeneous lockdown regulation actually amounts to focused protection of wealthy people because of the circumstances in which they're living. So the term focused protection was used by the authors of the Great Barrington Declaration, and it became associated with measures that are designed, you focus your protection around certain people, and other people have different restrictions. What I'm saying is that in this situation, just a universal recommendation across an unequal population effectively means focused protection for wealthy people. This increase of these cases in the first wave mean that the herd immunity that was built up in the country as a whole, or has been built up, was borne by the burden of doing that was borne by people in townships and poorer people. And you can see this by the fact that in the second wave, was much more severe in the suburbs. I'm not going to talk too much about excess deaths. There is an interesting situation here where there are many more excess deaths than there are COVID recorded deaths. And it could be due to data. It could be due to other causes. But I'm just not too sure what exactly is causing those excess deaths. And then there isn't cause of death data available, so it's very difficult to work it out. There are, however, clearly indirect health effects of locking down. The trouble is that, again, it's very hard to get data on them at the moment. There's likely to be a future rise in HIV. There's an elevated risk of measles and other diseases, future malnutrition, substance abuse, mental health problems, and so forth. So there's clearly costs of locking down. And I think the core question in public health is always, will it work for you? Nancy Cartwright emphasizes this. The same intervention can have different effects in different places. And in some senses, it's not the same intervention at all. So implementing a law, trying to implement a law affecting a lockdown just won't reduce social contact by 75% in all places, either because people won't stay at home, or because even if they do stay home, it still won't affect that reduction. And also, regulations are adhered to differently in different places. In Stockholm, in Sweden, merely suggesting that people do something is enough in many cases to get them to do it. In many places in the world, even a law requiring you to do something doesn't get many people to do it, and enforcement ends up being quite brutal in those situations, and was in many places. So one size just doesn't fit all when it comes to public health. So I'm now going to argue that the burden of lockdown falls on the global poor. So to do this, compare just two countries that are quite contrasting. They're not the richest and not the poorest, but close to it. Malawi is a very poor country in Africa. It has a median age of 17.2. In the UK, the median age is 40.5, so it's 2.4 times older in the UK. The GDP in Malawi is about 7 billion, and it's about 2.8 trillion in the UK. So the UK as a nation is about 400 times richer. On a per capita basis, that narrows a bit. It's merely 100 times richer, but that's still a lot richer. The number of COVID deaths per million in Malawi, I need to update this. This is a couple of weeks old, but it's only a couple of weeks ago. Was about 51,000 in the UK and about 185 in Malawi. So the UK is considerably harder hit by COVID. And the data here in Malawi aren't reliable, it has to be said, but it's nonetheless the case that it's, I mean, I have students from Malawi, but I do know people from Malawi, and I certainly have students from other African nations, and it's not, you know, in many places, it's just not a thing. Nobody knows anybody with COVID. It's not apparent in people's daily lives. So age and wealth are strongly correlated around the world, as these maps show that. I think that's quite well known. Age and risk of serious or fatal COVID-19 are also strongly correlated. And what that means is that you get a correlation between wealth and risk of serious COVID-19. This has been masked by the discussion of the fact that in wealthy countries, poorer people are more at risk of serious COVID-19 and certain racial groups and so forth. Those things are all true, but those results are swamped by the global on a global scale. So globally, the poor of the world are relatively less at risk compared to the wealthy because of the role of age. The impact of COVID-19 is also correlated with wealth. And the indirect health impact of lockdown is inversely correlated with wealth. What that means is that locking down as a global recommendation results in a reduced health burden on the rich and an increased health burden on the poor, even though there might be some poor people who benefit and some rich people who suffer. The effect of a global policy to lock down is to significantly increase the health burden on the poor relative to a mitigation approach. I'm not saying relative to doing nothing, I'm saying relative to a mitigation approach. I'm going to skip this slide and come to the argument that the use of lockdowns is due to their favoring the interests of the rich and powerful. The argument here is an inference to the best explanation. We have a lot of people dying every year of conditions that are not dissimilar to COVID, to the way that COVID kills people. So pneumonia killed 800,000 children in 2017, according to UNICEF. Each year, about 5 million children under 5 die from largely preventable causes: sepsis, pneumonia, malaria, various infectious diseases, neonatal causes. That's a lot of children dying, and it doesn't trigger a global prevention effort. And I think that the best explanation I can think of is that most of these children are very poor. That is supported by the fact that rich children don't die of these things, very rarely die of pneumonia. I'm just not sure there's any other explanation for this. you might object that COVID-19 hits the poor harder. It takes a disproportionate toll among ethnic minorities and disadvantaged groups. This is true in developed countries, where the term ethnic minorities is applicable. But it's not, I think, correlated. So in developed countries, poverty correlates with the risk factors for COVID-19, like obesity and heart disease. But poverty doesn't correlate with these risk factors in poor countries that are prior to going through the epidemiological transition, where people tend to die of infectious diseases, where a lot of people are dying as infants. In those contexts, what that means is that age is the overriding factor. So it is true that you get this reverse gradient within wealthy countries, but it's not the case that COVID-19 hits the poor harder globally. That's actually kind of an instance of a Simpson's paradox inference. And then finally, lockdowns are as much right as left politically. Does all this mean that lockdown is wrong? Well, I've not argued that. I think you could mount a left-wing argument for lockdown because it means restricting people's liberties for the sake of the public good. And that's why in the West, people have associated with the left. But you could also resist it on a left-wing basis that it's anti-egalitarian. And you could promote it on the sort of right-wing basis that nations and wealthy people should protect themselves. And if they're in a position to do so by implementing regulations, then they should do so and have a right to do so. So I think that the right could just as easily have adopted lockdown. And the reasons for the alignment, the ideological alignment, aren't really to do with intrinsic philosophical characteristics of lockdown. They're to do with personalities and geopolitical factors. So to summarize, I've argued that several common arguments for lockdowns fail, that many actual lockdowns have been unjustified and wrong. I've argued that globally lockdowns shift the burden of disease from the powerful and the wealthy to the less powerful and the poor. I've argued that the global preference for lockdowns is due to their favoring the interests of the rich and powerful. And I've argued that the favoring of lockdowns by the left and the rejection by the right doesn't have much to do with their intrinsic character, and that there is much right as left and vice versa. Thank you very much.
Thank you, Professor, for your wonderful lecture. We can maybe have a few questions from the audience for the lecture.
I also don't mind if people want to type questions in the chat, if the chat is enabled.
장영 박사님. 네.
Hi. This is Young Jang from Korea Institute for International Economic Policy. And thank you for a very interesting lecture. It was very inspiring and it was extremely interesting because I was in South Africa when the lockdown began. And I was doing postdoc research in Stellenbosch. So okay. Yeah, I was there and I kind of escaped after 7 or 8 weeks. So it was level 4 lockdown when I was leaving on special flight. So, and I agreed that the lockdown wasn't very effective in containing the disease in South Africa. I think it's just containing the spread within containing the spread across the regions, but within the regions, anything was changing. So yeah. It was not effective. That was my thought. But what if it's, I still think lockdown is useful if it's temporary and if it, gives some time to prepare medical capacity, like medical personnel or facilities, ICU beds, and even facial coverings or something like that. If you do some temporary lockdown until you are prepared, maybe it's effective. And maybe you need some time for people to change their perception and behavior, adequate for the era of pandemic, and to give some time for that, maybe lockdown is effective. What do you say? About that?
I agree. I agree with that. If you're the trouble is that it very quickly became not a short-term measure. So it was, this point is familiar. Many people have made this, but when lockdowns were first proposed, they were supposed to be a matter of a few weeks. You remember in South Africa, it was supposed to be 3 weeks, and then the president came on and said another. And this was the same in many places. So that's what I'm struggling with. I agree with you. You can say to a country, even quite a poor country, stay, just lock down for a few weeks. Like you can do that, and it might be reasonable as a precaution. I just think that's not what it has come to mean. And it also doesn't explain, that doesn't, or rather, it doesn't justify, say in the UK, the fact that it's now seen as the go-to. This is what we do. I know the UK is different because the UK, it's much more complicated. It arguably it has much older populations and is much richer. So arguably the risks are higher, and it also has the resources. So it's a completely, in my view, different argument. But still, the fact that it's become a very it's seen as the go-to measure. That's what I'm interested in. But I do agree that it can be a good precaution. However, I did in South Africa, I did actually think at the time that it wasn't. I didn't think it was, because I thought it was just obvious that it wasn't going to be effective. And I actually wrote some stuff at the time saying this just isn't going to work. So even for a precaution, you have to have a reason to think it's going to work. And I don't think, I think that the way people live in many parts of the world is such that it's just never going to work. So I agree with you. It can be, and in many places perhaps can be a good thing to do. But I do think still there are some places where I just don't see how it can possibly, I don't see how it can possibly be effective.
In my mind, there are some countries like Norway, Finland, or Australia, or New Zealand. I think it was quite successful. The stronger initial response was quite successful in changing and preparing and changing their behavior. But I guess it's not applicable to some poor reasons. I agree with that. It may not work on some reasons. Yeah.
The population of Finland is less than the population of Johannesburg. I think there's 7 million people in Finland, and there's 11 million in Johannesburg. In Soweto, which is a township in Johannesburg, I think there's 1.5 million. I agree. There are some nations where it is a different story. Absolutely. Also, the borders are less porous. You don't have migration. There are many immigrants from other African nations and so. So I think I agree with you. So this is why I'm saying I don't want to say it's never right. I'm trying to highlight the fact that it might be right in some places, but completely wrong in others. And I think that's what I want to. That's perhaps how I should present it. Is being clearer that it's you can have a kind of a reversal almost. So something that's absolutely the best thing in one place is absolutely not in another.
Thank you.
Thanks.
So another question? 오주환 교수님 질문해 주십시오.
Hi. It is so nice to listen to your very strong voices and also very reasonable voices. If I met you in this discourse last year, I might be my well-being might be much better than current. I don't know if you followed the India cases. That seems to be much more very close to your argument. partly because India was very good even before lockdown. They did a very good job. However, suddenly they after adopted lockdown, then situation getting so much worse. Then every victim was actually the low socioeconomic status person after they applied the lockdown. So that example is exactly same as you mentioned in this course, this presentation. So if you had chance to follow the India cases, it might be really great. If you don't have it yet, then please follow that to make your story much more stronger. That is my first question and comment. And one more one is there might be eclipsed. The societal responsibility can be well ignored by the lockdown panacea by the populist government. So that the eclipsed part is societal responsibility, such as isolation and quarantines. That is a transient nature, 2 or 3 weeks, as you mentioned. Lockdown can be also 2 or 3 weeks as the first promise, but it was sustained too long. However, if quarantine and isolation as only for small population of the walling off of the infected people and also contacted people to the infected people. So by doing that way, the other people, most of the population can maintain their own near normal life so far. If they argued isolation and quarantine rather than lockdown, the world might be much more different compared to this situation. That was already mentioned in the JAMA article in the 2007 by analyzing the 100 years of pandemic 100 years ago. So that they mentioned isolation quarantine was most effective, and the banning of public gathering, and also the school closure was alternatively also effective. Having three together is most powerful, but as a single measure, isolation and quarantine is much more powerful than banning of a public gathering. Banning of a public gathering is partly similar to lockdown. So that is much more individual level of responsibility rather than societal level action responsibility. So that I would argue the previous commentator, Dr. Zhang, who mentioned the buying time for public adjustment by this lockdown, rather than adjustment by the people, the individual action, it can be rather buying time for the societal responsibility preparedness, such as testing capacity scale up and also contact tracing capacity scaling up, and isolation and quarantine temporary space built up as a function center in China, so that can be legitimized. That can be going with your argument together very well. Some buying time by lockdown, if it is really necessary, because of unpreparedness. So that discourse can be very well aligned with you, even some different, seemingly different argument, but that can be very well complemented to your big the discourses. So I was very happy to listen to your presentation today. So I strongly agree with you. Thank you.
Thank you. Those are all very good points. I tried to get some of them, but I might write to you afterwards to get some of them. But I really appreciate that. Regarding India, I didn't follow it closely. And I know I should. I've just been busy with other things now. But I know that early on there was an absolute disaster when the government tried to implement a lockdown with 4 hours notice. and that's a very dramatic example of how wrong it can go when the world says this is the right thing to do, and then you just create this panic. And I think the responsibility, obviously the Indian government was wrong to do that, but I think the powerful nations of the world, the developed nations, need to understand that their decisions and what they say have these consequences in other places. They just do. And I think that you know, they need to accept some responsibility for those kinds of missteps. But I'm going to look now carefully at India. I think that's very helpful. And your other points are very helpful as well. I'll look at that JAMA 2007 paper. I might write to you and ask about it. Thank you for that.
Thank you.
Thank you. I see there is a question in the chat. Shall I answer that?
Okay.
I agree that lockdown by confirmed cases aren't recommended. Which policy or action is useful at the country or county level? Well, I think the previous question was actually quite useful for me here, because I think that, you know, it gave some answers to that. So there are other things that you can try to do. You can isolate you can isolate cases. You can also put limits on things. So you can, instead of, for example, banning all public transport, you can say that public transport should have reduced capacity. So that, you know, I don't know whether that's effective or not. I mean, the point is just that you can do, you know, you can do different things. And I think these things are also not the same. Oh, I see this stringency index thing. Yeah, I do have thoughts about the stringency index. I think it's important to realize that these measures are not all the same. And one of the problems with this stringency index is that it just kind of sees everything as on a single scale. And from a public health perspective, that's obviously not true. I mean, some things might be very effective and some things might not be effective. And then from an impact, a social or political or economic impact perspective, things are also not on a single scale. They're just different. The societies are very complicated. So banning education, well, banning schools has one kind of impact. Banning, closing retail shops, for example, has another kind of impact. Closing pubs has another kind of impact. And what's more, these impacts are different in different places. So if in South Africa you close schools, you effectively, you significantly impact people's education. There's no online, there's no question of online provision for many people, although for some people there isn't for many others. So you also increase inequality in an already unequal country. And you also deprive a lot of children of meals, because there is so South Africa has a poor education system at school level. The outcomes are very poor, but it has very good access. So most children do go to school. They just don't learn very much there. And what they do, however, get is food. So there is a school feeding program. So a lot of poor children are getting at least one square meal a day because they go to school. So if you close schools in South Africa, you also cause a nutrition problem. The situation might be entirely different in a country like Korea, which is much more internet enabled. And I know that I don't think schools were closed in Korea, but I mean, that's another. Take the UK. I mean, you'll encounter some of the same impacts, but they won't be the same. I mean, there'll be some similar impacts, but they won't be the same. And so, to see these things on a scale like that, I think it's just not that helpful. The same regulation might be implemented differently in different places. It might have all kinds of different effects, both on the disease and on normal life. So it might not even be as strict in another place, because maybe some education is already online anyway, for example. So I think that that's what I think about that stringency index. I think it's too simplistic. I also think, by the way, that just in response to the first question, that the best thing is also to consult to some extent. And early on, I worked with a filmmaker to make a film called COVID on the Breadline about COVID-19 in very poor situations. And one of the things that the crew did was talk to some people in Malawi in a village and ask them what they thought about this and what they would suggest. They explained the risks, and said, what do you suggest? And in the village, what they came up with was, they said, well, we'll have this half of we'll put all the older people in this half of the village, and we'll have all the younger people in the other half, because it's a rural village. It's possible to do that. The space is not an issue, and that's not a solution you could apply in a suburb in a Western country, but it is a solution you could apply in an African village. So I think you do have to also look to people who live in these situations and ask them, because they probably know better how they live than other people. So I also think there's some consultation that needs to happen. Yeah.
Okay. Unfortunately, it's time to end this seminar. Thank you very much for your excellent lecture. I hope
Thank you so much. Really enjoyed it.
I hope to see you in good health next time, in face to face.
Yes. Yes.
Thank you
Absolutely.
again, Alex.
Thank you so much. I really enjoyed it. Thanks to everyone.
예, 이번 세미나 마치도록 하겠습니다. 참석해 주신 모든 여러분 고맙습니다.